And this is a slightly difficult topic, and I just request you to just try and be a little more awake. I know your splanchnic blood flow right now is much more than the cerebral blood flow, but maybe we need to try and divert the blood flow towards more vital organs at this stage. So we know that severe sepsis and septic shock is a major problem, and one of the major goals of treatment of septic shock is to control infection. And we know that in the control of infection, antibiotics play an absolutely central role, and getting the antibiotics right and getting them in on time is very, very vital to successful management of our patients. And we know from this study by Anand Kumar that every delay of 1 hour in giving the right antibiotic leads to an increase in mortality by almost more than 7%. Now, we spend a lot of time debating, talking, discussing which antibiotic, what class of antibiotics, whether to escalate, whether to de-escalate, and all those sorts of things. And we have guidelines on all these sorts of things, and they all tell you the same thing, that give the antibiotics, get them right, give them early, give them fast, hit hard, hit fast, broad spectrum, and then reassess and de-escalate. And I think we are well versed with that. The real question is, once we know which antibiotic to give, once you've decided on the antibiotic, maybe it's the right one, maybe the choice is right, you still have to make sure that you're giving the right dose, and that dose of antibiotic that you're giving is going to achieve the required concentration, and that is going to have the desired effect, that is maximum microbial killing. And so what I'm not going to talk to you about is not a general lecture on pharmacokinetics and pharmacodynamics, but we'll restrict this one and focus on pharmacokinetics and dynamics as applied to antibiotic therapy and sepsis. And we'll stick to broad principles because this is a short talk and it's postprandial sort of lecture. So pharmacokinetics, very broadly speaking, defines what the body does to the drug, and this curve traces the concentration of the drug over time. And pharmacodynamics, or PD, I'll call it as PK and this is PD, represents what the concentration that is achieved, what effect it has. In other words, it is what the drug does to the body. So again, if you have given a certain dose, the concentration of the drug in the blood is determined by a number of factors, which we call as the pharmacokinetic or the PK factors. The drug reaches a concentration. It reaches at the target site, which may be the lung if you've got a pneumonia, or the abdomen if you've got intra-abdominal sepsis, but may also reach other sites like the kidney, for example, and then you might get a toxic, beneficial effect, or you may get a toxic effect, and eventually that's going to determine the outcome. And the effect of all this concentration, the effect that this concentration has is called as pharmacodynamics. And what we call as the PK-PD parameter is essentially nothing but the dose versus effect relationship. So it is a combination of the pharmacokinetics and the dynamics of the drug. Now I'm going to list about 7 or 8 factors. I just need you to keep them in mind. The first one I want to talk about is clearance, and that is the volume of blood cleared of drug in unit time, and you can just think of it as the way the drug is leaving the body. The volume of distribution, we'll talk about that later, and the half-life, that is the time required for the plasma concentration of the drug to come down by half. The Cmax, or the maximum concentration, is a peak concentration that the drug achieves in the dosing interval. The minimum, the concentration minimum, the Cmin, is the minimum drug concentration in the dosing interval, and the area under the curve. So under that curve which you saw of the concentration to time, the total area under the curve over the entire 24-hour period is the area under the curve. So this is what I mean. So now imagine you've got an infection, you've got a microbe, and this microbe is inhibited at this minimum inhibitory concentration. So this is the MIC, and if you achieve a drug level of this, then you're going to achieve inhibition of microbial growth. Now, different antibiotics work in different ways. And here you've given an antibiotic. This is the peak concentration it received. And then, because you've given a bolus, the concentration is now decreasing steadily over time, depending on its clearance and its half-life and so on. Okay. Now, some drugs, they work best when you maintain a steady level above the minimum inhibitory concentration for a prolonged period of time. So the time at which the drug level is present greater than MIC, the time more than MIC is an important drug pharmacodynamic factor, and most of the beta-lactams, the carbapenems, they depend on, the killing depends on time more than MIC. We don't need to get a very high concentration in, we just need to make sure the drug level remains above MIC for a prolonged period of time, and that ensures maximal activity of your beta-lactams. On the other hand, there are drugs like aminoglycosides, where you need, the higher the concentration that you achieve, the higher is the killing and the greater is the killing, and therefore for many of these agents giving a big whack of these drugs, achieving a very high concentration, so the Cmax, the concentration divided by MIC, so the higher the ratio of peak concentration to MIC determines maximum killing for these drugs. So for these drugs you need to achieve high peak concentrations. And for some drugs, for most prominently the fluoroquinolones, both the time, the concentration and the time are important, so the area under the curve is an important pharmacodynamic factor which maximizes effect of the drug. So now we know that some drugs need to maintain a steady level, not a very high level, but a steady level for a period of time above MIC. For some drugs you need to achieve a very high peak concentration, and for some drugs you need to achieve a high peak concentration for a prolonged period of time. And how do we achieve these parameters will depend on the pharmacokinetics of the drug. In other words, how the body handles the drug. So let's look at some of the pharmacokinetic parameters, and one of the parameters which we need to understand is what we call as the volume of distribution. So if I give X amount of a drug, I give it intravenously into the blood, just as in the diagrammatic sort of scheme, okay, and then once I give it into the blood, then I measure the concentration. Now if the drug is distributed in a large volume, then the concentration of the drug will be much less, and if it's distributed in a small volume, the concentration of the drug will be much higher. So this is drug, the red dot which was distributed into a, so this is a drug, it's going into a large volume and you get diluted sort of drug over here. On the other hand, if it goes into a small volume, you get a higher concentration in the blood. So in other words, the plasma or the peak plasma concentration will depend on the dose that you give and the volume of distribution. And the larger the volume of distribution, the smaller will be your peak plasma concentration. Right? So for drugs, so if you know that a drug has a high or a large volume of distribution, then you know you need to give a larger dose in order to reach the initial peak concentration. Is that reasonably clear? I need to know yes or no, then I can move on. Okay, great. Now, there are drugs which have a large volume of distribution and there are drugs which have a small volume of distribution. Those drugs which we call as hydrophilic, which are attracted by water, which stay within the water, and the water which is bound in the blood or in the plasma, bound to albumin, these are the hydrophilic drugs. So if the drug has a small volume of distribution which is restricted to the plasma volume or the blood volume, these have a low volume of distribution because this is just being restricted to the blood volume, which is only a small part of the total body water. And so a hydrophilic drug will achieve a very high peak concentration. And these drugs we call as hydrophilic, and most of them are protein bound to albumin. And because albumin by and large in a normal healthy individual does not leave the vascular compartment, the volume is confined to the plasma volume. And these drugs have a low volume of distribution and they tend to reach a high peak concentration relatively early. On the other hand, if the drug is such that it diffuses and goes into the fat and to the other tissues, so it diffuses the tissues, then you can imagine the total body water and the total volume of tissues in the body is extremely large, and therefore they will have a very small peak concentration. So if your volume of distribution is much more than your plasma volume, then these drugs will tend to achieve a very low concentration in the blood. These drugs are lipid soluble, that is why they dissolve rapidly and assimilate into the different tissues. They are not protein bound and therefore they don't stay confined to the blood plasma volume. So these drugs which have a large volume of distribution have achieved low peak concentrations, and therefore you need to give large doses and repeated doses, so large loading dose to fill up this whole sort of blood volume and the tissue volume, and not related to antibiotics, but amiodarone is one drug where you need to give loading doses before you can achieve a sort of stable effect. So the volume of distribution is important because that determines the peak concentration of the drug. Now a drug which is given has to leave the body, and clearance is defined as the amount of blood that is cleared of the body in unit time. So this drug comes in, it's diluted into the volume of distribution, and then it leaves the circulation, right? So if the drug is leaving the circulation and you want to maintain a certain dose, then you need to replace the amount of drug which is leaving the circulation. In other words, You've achieved a level with a loading dose, which is dependent on the volume of distribution, but if you want to maintain a steady level, then you need to know the clearance, because that will guide you as to how much drug you need to give to keep that level of drug steady in the blood. Right? So these are two big sort of parameters which we need to understand to know how much drug to give to get an effect, and what rate to give an infusion, or how frequently to repeat the drug so that we maintain a steady level in the blood. Is that also reasonably okay? Okay. So, and half-life is the time required for the plasma concentration to decrease by half, and that will depend on the clearance as well as the volume of distribution. Now, this is all in normal healthy individuals. It's fine, and now the reason why these lectures are confined to the intravascular compartment, fluid leaks out into the interstitium, so there is increased capillary permeability. There will be hypovolemia, there's very often hypoalbuminemia, so the albumin levels go down. Depending on the stage of sepsis and the degree of organ dysfunction, you have reduced perfusion to the liver, reduced perfusion to the kidneys, renal dysfunction, hepatic dysfunction, and very often scope for drug interactions because of polypharmacy. So let's see what happens when capillary permeability increases. Now, like I said, for a hydrophilic drug, which was confined to the blood volume, right, in the normal healthy individual, when the capillary permeability increases, all this sort of fluid leaks out into this was a normal circuit slide which I showed you, normal situation. This fluid leaks into the interstitium. And when this fluid leaks into the interstitium, the drug is not, the volume of distribution is now not just the vascular compartment. The volume of distribution is the vascular plus the interstitial space, and therefore the volume of distribution increases. And this volume of distribution will increase in volume of distribution tends to lead to a reduction in the peak plasma concentration that you can achieve with the same dose of the drug. Now, which drugs are going to be most affected by an increase in volume of distribution? If we just take a step back, those which are confined, already only confined to the blood volume, only confined to the blood volume, the hydrophilic drugs are the ones which are going to be maximally impacted by an increase in volume of distribution. Those which are anyway widely distributed are not going to be affected if there is increased capillary permeability. But for those drugs which were confined to the plasma volume, which were hydrophilic, which had a low volume of distribution, their volume of distribution is going to increase when the capillary leakage takes place, and these drugs are going to have decreased levels for the same dose. And therefore, drugs which are hydrophilic, like beta-lactams, aminoglycosides, glycopeptides, linezolid, and colistin, their drug levels are likely to be reduced when capillary permeability increases severely in sepsis. And it is also very important to understand that the capillary permeability is maximum in the early phase of sepsis when inflammation is at its peak, and that is the time when you really need your biggest dose of antibiotic in the circulation at the target site, and you need to make sure you're giving the right amount of antibiotic at this stage. Lipophilic antibiotics, which already have a large volume of distribution, are unlikely to be majorly affected by an increase in capillary permeability, and these drugs are the quinolones, macrolides, and the tigecycline and clindamycin. Okay, so what happens when tissue perfusion goes down? We know that the antibiotic has to reach the tissues, and if the antibiotic doesn't reach the tissue, because of poor tissue perfusion and severe sepsis and septic shock, then you're not going to get an adequate level in the tissue. So there is data to suggest that in septic shock, the concentration of piperacillin in interstitial fluid was 5 to 10 times lower than that in the plasma, and it was 3, whereas in healthy volunteers, it was 3 to 4-fold higher. So there's very clearly evidence that if you have poor tissue perfusion, your antibiotic is not going to reach the tissues. So in septic shock, you've got a low peak level because of high volume of distribution, and your poor tissue perfusion means the drug is not reaching the tissues. Very often, this is a very important and underestimated change which takes place in septic patients. Now, we all used to the fact that in renal dysfunction, the renal clearance doesn't take place, and therefore the drug level rises in the blood. But in patients with septic shock, they are hyperdynamic. You give them fluids, you give them inotropes, you give them dobutamine, the cardiac output goes up. When the cardiac output goes up, the renal blood flow can increase, and that can increase the renal clearance. And therefore, what will happen is the increased clearance of drugs eliminated by glomerular filtration will result in lower drug levels. So in hyperdynamic phase of sepsis, it is possible that you will actually achieve lower drug levels because the renal blood flow and glomerular filtration is significantly increased in about 30% of patients, and that can actually lead to lower drug levels rather than high drug levels, which you tend to associate with renal dysfunction. So if there is no renal dysfunction and you've got a hyperdynamic circulation, there is a good chance that you're eliminating a lot of drug via the kidney and you might get lower drug levels. On the other hand, this is very expected and predictable. If you've got renal or hepatic dysfunction, then your drug levels will be much higher and you may also run the risk of toxicity. The one point I would try to make here is that in patients who've got an acute change in creatinine or in acute renal failure or acute renal dysfunction, if you want to try and calculate the creatinine clearance, please don't use these formulae. They are very good for stable chronic renal failure patients to estimate the glomerular filtration rate from the creatinine and age and so on. But in acute renal failure, you should actually try and measure the creatinine clearance either by a 24-12 weight or even a 2-hour urine collection. The other important parameter which is altered is protein binding. Now we know that it is only the free form or the unbound fraction of the drug which is the active component of the drug. So if a drug is protein bound, it is not active, and it is the drug which is free and not bound to protein which is active at the receptor site. Now in sepsis, when the albumin level goes down, which it does very often because you've got increased capillary permeability, albumin is going out in the interstitium, you've got decreased synthesis by the liver, the impact of cytokines and so on. So you have low albumin levels in sepsis. Now, therefore, the unbound concentration, a fraction of a drug, can increase. However, that also goes out into the interstitium. That is also diluted by fluid going out in the tissue, and therefore antibiotic concentration in the tissue remains low. Right? So again, hypoalbuminemia leads to reduced antibiotic concentration at the effector site. Metabolism usually takes place in the liver, and drugs which are metabolized by the liver can be sort of grouped into 3 groups. Those depending on the hepatic extraction ratio. And again, this is slightly technical, but just bear with me for half a minute. Some drugs, they have a high hepatic extraction ratio. So a large amount of the clearance is very close to the liver blood flow, right? So if this is high, then the clearance will depend on the renal blood flow and not on the liver function. So if the liver blood flow is reduced, then there will be significant reduction in metabolism of these drugs. Otherwise, there's no change. On the other hand, if you have drugs which are not dependent on the liver blood flow, but on the enzymatic functions of the liver, on the liver function itself, then these drugs are significantly affected by a fall in liver function. And drugs like clindamycin, their levels can go up significantly if liver dysfunction is taking place. So I know this has been a bit of a bombardment, but just to sort of summarize all this in a nutshell, in a patient who's septic, you can have an increase in cardiac output. That can actually increase renal clearance of some drugs if your renal function is normal, and that can lead to a low plasma concentration. More commonly, you have leaky capillaries, altered protein binding, and that leads to an increase in the volume of distribution, and that leads to low plasma concentrations. On the other hand, you can have organ dysfunction, like liver dysfunction and renal dysfunction, and that can tend to increase the concentration of the drug. Now, how do we put all this and give the right antibiotic in the right way? So, like I said, we talk a lot about the right antibiotic, but we have to give the right antibiotic in the right method, guided by PK/PD principles. Now we've got the beta-lactams and carbapenems. And in these, it is the amount of free drug concentration, the time over which the free drug remains above MIC, which is best correlated with efficacy. Right? So now there are 3 or 4 questions we need to answer. How much higher above MIC? For how much time of the dosing interval should it remain above MIC? Now, for most of these drugs, you should achieve about 4 times the MIC. The concentration which is effective should be about 4 times the MIC. So if this is the MIC, you should reach a concentration which is about 4 times the MIC. And how long, for how much part of the dose? So suppose you're giving, meropenem 6 hourly. So your dosing interval is 6 hourly. So for how much time of those 6 hours should the meropenem level remain above MIC? So the Cmax of more than 40%, if it remains for 40% of the MIC of the time of the dosing interval, that is adequate for stable, not very sick patients, sort of stops the growth of bacteria. In order to achieve 100% killing or close to 100% or maximal killing in patients who are sick with septic shock, you need to have the time more than MIC for almost 100% of the dosing interval. In other words, it is probably better to give this as an infusion of a 3 or a 4 hour infusion so that your drug remains at the therapeutic level for almost the entire dosing interval. And like we know that for these drugs, the peak concentration is affected by the volume of distribution, and the rate of infusion will be determined by the clearance. So for beta-lactams and carbapenems, the improved pharmacodynamic profile is achieved with more frequent dosing or by extended or continuous infusion in critically ill patients. So you could give, so what has been tried is 18 grams infusion of piperacillin over 24 hours, or a 3-hour infusion of 1 gram of meropenem, 8 hourly or 6 hourly, and so on and so forth. Okay. Now, aminoglycosides, like we said, the pharmacodynamic factor which best correlates with maximal efficacy is the peak concentration, the concentration above MIC. So this is called as a concentration-dependent killing. So so while the beta-lactams and the carbapenems have time-dependent killing, the aminoglycosides have concentration-dependent killing, and we must use the pharmacodynamic factors kinetic factors to achieve maximum peak level. Aminoglycosides also have a post-antibiotic effect, meaning that even when the drug concentration falls below the MIC level, the bacteria still remain killed. So there is some killing which happens even after the drug levels fall. So this sort of lends itself well to a sort of once a day big dose of aminoglycosides. So if you have a big bag, achieve a MIC, the level will fall, but even at this lower level of drug, killing will still take place because of the post-antibiotic effect. So you need to achieve a Cmax to MIC ratio of at least 10. So you must achieve at least 10 times the MIC, a peak level 10 times the MIC for clinical success. The other thing we need to remember is that the peak levels are corresponding to efficacy, but the trough levels correspond to toxicity. So you have to try and achieve high peak levels and low trough levels, and you should not give the next dose of aminoglycoside at this level. You should give it at this level when the trough level is close to 0 to avoid toxicity, because this level corresponds to toxicity. And therefore, ideally, in the ideal world, antibiotic such as aminoglycoside should be given by a single dose, as a big single dose, a single daily dose, and monitor the trough level. So when the trough level comes down to close to 0 or less than 2, you should then give the next dose of aminoglycoside. Okay, so the typical dosage schemes would be 7 milligrams per kilo of gentamicin, which is a big dose, which is quite a big dose, or 20 milligrams per kilo for amikacin. And therapeutic drug monitoring should be performed after the first dose. Glycopeptides like vancomycin is moderately protein bound, teicoplanin is highly protein bound, and these have sort of used the area under the curve, and that you need to maintain an area under the curve. And again, for vancomycin, you should achieve a trough level between 15 and 20 to prevent renal toxicity. So again, you should do therapeutic drug monitoring of vancomycin and monitor the trough level and give the next dose only when the trough comes down below 15 or 20. Fluoroquinolones, the PD factor which is best correlated with killing is the area under the curve. So the time related to peak as well as the time above the MIC. And in order to do this, we know that these fluoroquinolones are lipophilic drugs, and these drugs have volume of distribution has minimal effects on these drugs. What you really need to do is give a loading dose and give it at frequent at an interval, which ensures that the concentration remains above the MIC for a significant period of time. And you must get a Cmax, the peak above MIC, of at least 10 times, and the area under the curve to MIC of more than 125. So that is your best target. So for ciprofloxacin, I don't know how many of us use these doses of 1,200 milligrams per day. So you should give either 600 milligrams every 12 hours or 400 milligrams every 8 hours in patients with normal renal function in order to achieve the area under the MIC for these sorts of drugs. And if you don't achieve this kind of drug levels, don't achieve these parameters, then you're actually giving suboptimal or subtherapeutic drug administration, and that can actually result in resistance. So at the end, I just want to conclude that altered pathophysiology has a significant influence on pharmacokinetic parameters, especially the volume of distribution and the clearance. And knowledge of the PK/PD properties of these drugs can be used to personalize dosing regimens, especially where a therapeutic drug monitoring can be done. And it is absolutely essential that we do this in patients with severe sepsis and septic shock. One, to maximize antimicrobial activity, to minimize toxicity, and also, last but not the least, to reduce development of antimicrobial resistance due to subtherapeutic dosing schedules. Thank you.
Thank you, Dr. JDivatia.